The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. We're here for the next episode of TMD Demystified, and I am Tony Urbanek. It's Tuesday morning, and as usual, I would like to speak on another topic regarding the enigma, the conundrum of temporomandibular joint disorder / disease. I have a lot of experience with this problem. Actually, my experience with this problem goes all the way back to when I first began my studies in oral and maxillofacial surgery in 1973. So you do the math, you can figure out how many years I have been working on this particular problem. Those that follow me along already know that for 36 years I did surgery to try to help patients with this problem, try to correct this problem. For 36 years, I applied my surgical skills and did every type of TMD surgery that had been recommended, and many of those types I did hundreds and hundreds of times, all the way from total joint reconstruction to more minor procedures through the arthroscope. But half of the procedures I performed roughly were open joint surgeries where an incision is made in front of the ear, access to the joint is done, and then the surgical technique is applied depending on what the joint looked like and what the symptoms were, etc., what the x-ray looked like, to try to alleviate the symptoms of TMD. Because there was a thought at the time that the symptoms were somehow related to how the x-ray looked, which turned out to be not true. The symptoms are related to chronic inflammation within the joint, and that statement has been covered many times on many different episodes. So if you'd like to learn more about that, you can refer back to prior episodes. But for 36 years, I attempted to do surgery, and we had some good results that lasted a long time. In fact, I have recently, after roughly 50-year career doing temporomandibular joint treatment of one kind or another, surgical and non-surgical, I've had several of the surgical patients come back that I did surgery on one side of their joint, of their jaw, one side of their jaw, with complaints on the other side. And taking an x-ray of the surgery of that particular patient showing the surgical side looked pretty good. On the other hand, what I found after 36 years of doing TMJ surgery, that I could expect at least 30% of those patients back in my office within 6 months to 2 years complaining of the same symptoms, no matter what surgical technique I used. And to some extent, that included total joint reconstruction, which is a different bird. Total joint reconstruction is a very big operation. It's a very complicated operation. It's a operation with significant surgical side effects if not done correctly, or side effects even if it is done correctly. I'm not saying that a total joint procedure isn't ever necessary, but at this point in time, it is few and far between. Knowing what I've learned about treating TMD, and that is directly driven by chronic inflammation within the joint. So if you can make the chronic inflammation within the joint diminish, decrease, then the symptoms will similarly diminish and decrease. But the topic of today's, that's just a preliminary. The title of today's episode is OMG, oh my God, I can't stand it anymore. Oh my God, I can't stand it anymore. Well, what's the definition of it? Well, plug in TMD, TMJ. Now, what I'm going to make, this whole episode is about a single point that I'm going to make, but you would think, using this title, oh my God, I can't stand it anymore, I'm referring to the patients. And I chose this title, as I chose most of the topics and titles, based on usually my most recent experience with somebody that comes in the office, does a consultation, and stimulates my thought process to go over a specific point or process about understanding this problem. And you might think that, well, I'm referring to the patients. And so, yes, I had a patient last week who said exactly this. As we started the consultation and I started listing the symptoms that this patient had, or the patient started to list the symptoms to me, she blurted out, I can't stand it anymore. This is a patient, typical patient. They are not few and far between. In fact, they're the majority of patients we see in this practice that have had headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, various kinds of noises, and various kinds of problems with jaw locking or inability to open. Those are the most common symptoms of jaw joint problems. They're the common ones. There are a few that are uncommon that we're still trying to work out and validate as these symptoms are actually coming from TMD. Visual disturbances is actually one of them, but I'm not going to claim visual disturbances at this time. But I have seen, paying extra attention, patients who claim that their visual disturbances are also alleviated after treatment, non-surgical treatment of the TMD to decrease the inflammation in the joint. That is a whole different discussion, and I don't want to go there today. But as you may know, migraine headaches are distinguished from any other kind of headache because of the visual disturbances that are most often associated with migraine headaches. That's a different point. All right, so back on topic. I can't stand it anymore is what this patient said. And we had a long discussion about her history and how many doctors she had seen, how many dentists she had seen, how many convenient care or walk-in clinics she had gone to, and the numbers were staggering. She had a history of 30 years of symptoms, headache going back to adolescence, which is the most common history of headaches. Headache is usually the first symptom to show up, and in the females usually begins to show up in adolescence, 14, 15, 16, 17 years old. They will start having a history of headache, sometimes even before they start clicking the joint. The meniscus gets loose and starts to click, but even before then, quite often the headaches occur, and the headaches are directly caused by inflammation in the joint because of overuse of the joint. TMD is nothing more than a disease caused by overuse of the joint, either acutely or chronically, which develops chronic inflammation, which causes all the symptoms. That's the progression of this progressive disease. And if ignored, not treated, the progression of the disease gets worse. So a patient last week, and she had seen, I asked her, as I do sometimes, how many doctors have you seen for this problem over a period of time? And she really thought it through. I could see that she was trying to add them up. And she said, over the past 20 years, her history went back to adolescence, but she says, over the past 20 years, I have seen 30 doctors. And then we went through what kind of doctors. She had seen, I think, 3 general dentists. She had been to the oral surgeon. She had been to a couple PCPs. She had been to I think the number was 8 convenient care clinics at particular times when some of these symptoms of headache or jaw pain or earache began to express themselves acutely. And she went through the history of the different medications she had been put on. She had done dry needling. She had been to the physical therapist. The medications ranged all the way from anti-inflammatories up to antipsychotics. She had not had any TMJ surgery performed. Her X-ray was not particularly insightful, except it did show some subcondylar cyst formation on one side, which is almost always, well, is not almost, is a sign of chronic inflammation within the joint and loss of bone within the condylar head. So she was very distraught, and that is why it stuck out in my mind. A very distraught patient said, "I can't stand it anymore." And this is a typical patient we see here. We have a large practice on this problem. We get referred between 40 and 50, sometimes 55 or 60 new TMJ patients per month for us to consult with. And if they go through the process of using the device and protocol correctly, they will get the results that we claim, using the Urbanek device and protocol. They have to follow the protocol, though, and that is one of the issues I spoke on recently. But this title I chose actually was not because of the patient himself. It reminded me because when the patient said, "And I can't stand it anymore," and she had gone through the litany of resources that she had used to try to solve this problem, both financial and medical, the resources that had been spent trying to fix this problem, which obviously had not been fixed at that point, I had the same thought. I can't stand it anymore. I can't stand it anymore. Having these patients come in that have had 10, 20, 30 or more years. I have a few handful of people that have had this problem for 40 years and have been run around in circles, and spent hundreds of thousands of dollars on trying to solve something that is easily solvable if you understand it. And honestly, when she said, "I can't stand it anymore," the thought process that I had was, I can't stand it anymore. To see these people come in with something that can be relatively easily solved. And the reason it hasn't been solved is that the dental profession, whose responsibility it is to fix this problem, unfortunately, it is the dental profession's responsibility, has not actually looked into the actual cause of this problem, which I bring out clearly and obviously on all of these episodes in this podcast, in our seminars, in my teaching of this in lectures now. If you note a little frustration in my thought or my speech, it is. I am frustrated because I can't stand it anymore. I see these primarily women, some men, come in with years and years spent trying to fix this problem. They are making the rounds. They're doing their part. They're going to the doctors. The problem is the doctors either don't want to know anything about it. They close their ears if they hear TMJ. They literally close their ears, or they do something that they heard might work, that somebody else was doing. They throw it to the wall and see if it'll stick. That is the usual and customary, and I've spoken on this before. The dental profession, the dental establishment, does not want to look at the simple concept that chronic inflammation in the joint, in this joint, operates just like chronic inflammation in the elbow or in the knee, causing the muscles to get tight, which pull on the bone, which creates all the painful symptoms. And then the tinnitus, subjective hearing loss, fullness in the ear, dizziness and vertigo are created by chronic inflammation fluids getting into the middle ear from the glenoid fossa, from the temporomandibular joint fossa, via the petrotympanic fissure. The proof of this is that when you unload this joint, unload the joint, it allows the chronic inflammation to go down to the point where when you do a pre-op examination or a pre-treatment examination and push on the joint, it hurts. And when you do a post-treatment examination and you push on the joint, it doesn't hurt. If you have a bad knee, you go into the orthopedic surgeon's office and you describe your symptoms, he's going to walk across the room and squeeze your knee. And what he wants to find out is, does the knee hurt? And he squeezes the knee to find out whether it's chronically inflamed. And if it hurts, it's chronically inflamed. If it doesn't hurt, it's not. That same thing applies to this joint. So when you push on a joint and it hurts, you know one thing: the joint is chronically inflamed. It's inflamed. And again, because inflammation drives all the symptoms, not overuse of the muscles. Overuse of the muscles is overuse of the muscles. And muscles do go into trismus, but it's not overuse of the muscles. It's chronic inflammation in the joint. And I just say again, I can't stand it anymore watching these patients come in that have been abused, unintentionally, but abused by the system. The medical doctors, they know they don't know anything about it, and they only can say, go see your dentist. They don't know that the dentist doesn't know anything about it unless they are involved in what we do here. Yes, there are extensive TMD. In fact, we now have extensive TMD programs. We have a specialty in TMD facial pain now. And again, it is nearly impossible to get this information into that area of dental specialists who don't want to hear it. They want to do complicated things. They want to do multiple things. They want to game the medical system to try to get the medical system to pay for TMD. I say that, I back it up. No one disagrees with me. No one even criticizes. I can't get anybody to criticize that statement because they know it's true. So if you're listening to this at any point in time, either within the near time that it is produced and disseminated, or in 10 years, it is important for you to understand that the medical doctors, the orthopedic surgeons, they're not geared to treat TMD because they know it has something to do with teeth and it has something to do with the jaws, and that's not their area of interest. So they say, go see your dentist, and the dentist, for one reason or another, for one thought process or another, they really don't want anything to do with it because historically everyone knows nothing works. And no one has disagreed with me on that issue either. All the doctors, all the dentists I have spoken to and told this part of the story, they all shake their head and go, yep, we know nothing works. It's amazing to me that now that the information is out, there is still so much resistance to actually listening to some basic science, some basic technical knowledge that I can disseminate, teach, that applies to this particular problem. You were taught in dental school that this joint is unique. This joint is different. This joint is so different that you're never going to understand it. Well, that was a terrible thing for a dental university, dental college, dental school to do. To start out by teaching the young dentists, training dentists, dentists in training, that they'd never figure it out. Well, that's one reason nobody ever looked. They were told from the beginning it's complicated. and no one really knew what to do about it, and everybody knows that nothing works. So here we are in 2024. The month is October of 2024, and there are literally millions of people highly weighted toward females, 90% females, 10% males, who have this problem on a daily basis. Many of the histories go back 20, 30, even 40 years, that have sought some kind of relief and some kind of explanation for their problem. And all they get is double talk and I don't know, and go see somebody else. That is why I can't stand it anymore. But I'm going to keep trying. There is no way that any general dentist, oral surgeon, orthodontist can't learn this simple bit of technology and understand how using a device that simply separates the posterior teeth long enough to get the inflammation to go down, and then use it consistently according to a protocol, that it can't help these patients. Of course, you have to use a device that they can speak with, because you got to wear it 24/7 for a while. You can't just give it to a patient and say, here, use this as you please. The patients need to be followed up for various reasons. The biggest reason is because the patients know, the doctors know, that when you put a device in the mouth that separates the teeth, the mandible is going to drop back into centric relation. And if there's a large enough difference between centric occlusion and centric relation, that can create in itself a problem. But that's only going to show up when you separate the back teeth by an anterior device that only the front teeth touch, canines and incisors. There are other issues that can come up as to why the patient needs to be followed, but you can't just give a patient a device and say, good luck. So there is a little bit of technical knowledge. There are a few nuances how to treat these patients and follow up and make sure that the patient themselves is well educated how to use this. And when the patients are well educated, and big question, and the patient will follow the protocol. Admittedly, some patients will not follow the protocol for their own reasons, to their own detriment. But that is a fact, and we have to deal with that. So you are not responsible for patients who won't follow the protocol, as long as you make sure that you're absolutely certain that you have educated them on the protocol, the importance of the protocol, how the device works. At that point, if everyone will step up and do their part, both patient and doctor, patient follows the protocol, doctor does the proper education and follow-up, the success rate is extreme, into the 90s, 95%. Really, the only patients that don't do well are the patients, one way or another, who don't follow the protocol. And unfortunately, there are plenty of them, just like there are plenty of doctors who don't want to listen. They hear TMD, they already know that they don't like to see those patients in their practice. There's nothing they can do for them, or if they do, make a night guard and send them out with a night guard, the patient will be back within a short period of time saying it didn't help, or sometimes even makes it worse, frequently makes it worse. And now they're kind of, quote, as they say, married to the patient, and they don't want to do that, trying to fix a problem with a night guard that admittedly has no effect at all on temporomandibular joint disorder disease. 50% of the dentists make a night guard, and basically what they think is, I hope you don't come back. You go to someplace else, some other doctor. The oral surgeons, they don't know what to do about it. There are still a few oral surgeons who do surgical treatment of the temporomandibular joint, but now in 2024, those are few and far between. It has been proven that the majority of temporomandibular joint surgical procedures are ineffective to one degree or another. Again, I said that we have, with 36 years of surgery, there have been many cases it's been effective, but 30% of the time they were back in the office. in 2 months to 2 years, and that wasn't good enough, which is the reason I went off and began doing the research on what was really going on here. What's really happening with this thing called TMJ? So I have the experience, the surgical experience for 36 years, the non-surgical experience for the past 14 years, and the experience being inside, literally being inside over 2,000 temporomandibular joints, being able to see what the joint looked like, the damage in the joint, the experience with using surgical procedures of one kind or another, the effect of that, and now the effect of non-surgical treatment by unloading the joint. If you unload the elbow, which is the proper treatment for tennis elbow, then the pain in the forearm goes away. If you unload the temporomandibular joint, the pain in and around the face goes away, or the neck pain goes away, or the shoulder pain goes away, or the ringing, fullness, and dizziness goes away. It's pretty simple, pretty simple. So I'd like to just kind of leave it at that. I made the one point that, it is to a greater degree continues to be very frustrating to have the patients come in and give these 30-year histories of being run around in circles. And they know they've been run around in circles. That makes it even worse. They are well aware that they have just been run around in circles. And some of them have been unwilling to give up, which eventually can end up in our office here in Middle Tennessee. And some of those patients just give up. And I've heard that many times. I just have learned that this is something I have to learn to live with. I've heard that so many times. I just have given up, and I'm just have to learn to live with this, have to learn with the subjective hearing loss, have to learn with headaches 3 times a week or once a day. I have to learn with my upper back and shoulder hurting all the time. Not necessary, not necessary at all. So we have patients that say, oh my God, I can't stand it anymore. And hopefully there'll be an increased number of enlightened dentists who join our network to learn how to treat this problem simply and extremely effectively by using a device and protocol that unloads the temporomandibular joint long enough to let the chronic inflammation decrease. Simple, really simple. That's it. All right, well, I've made the point, maybe a little too much. If you would like to learn more about this, you can get on our website at www.urbanektmj.com. There's a lot of information there. You also can, from that point, you can register for our online course, which teaches you how to do this, a three-hour online course, and which includes 3 CME credits, which will teach you how to do this, get you started well, also get you licensed to use the patented device because it is patented. Or you can attend one of our seminars, which are done quarterly here in Middle Tennessee, in Franklin, Tennessee, Brentwood, Franklin, which is usually an 8-hour seminar, which goes over a lot more details and gives you insight in how the device is made in our manufacturing facility here, getting the tour of the manufacturing facility and having access to all the people in our organization, which is a great added benefit to becoming a network provider. With that being said, I look forward to the next time, which will be next Tuesday, that we meet again. I look forward to any questions or comments or criticisms you might send me. I can be reached at tony@tmjservices.net. Until then, I wish you a pleasant week and look forward to the next time I speak. This is Tony Urbanek, TMD Demystified.